So good morning. My name is Suchitra Ranjit, and I'm going to be discussing a few interesting pediatric ICU cases. Some of them do have a cardiac component and some don't, but they were pretty challenging, and I'm sure they'll have important lessons for all of us. So, yeah, the first case was a 1-year-old little boy who taught us the importance of careful assessment of vital signs. I brought this case up first because in this age of electronic equipment and blood gases and monitors, we quite often forget to examine the child the way we were taught in our MBBS days and rely on blood tests and reports and monitors. So this was a typical case where it was brought home to us that no amount of electronic infrastructure will help if we don't know the basic diagnosis. So this 1-year-old baby was the child of very computer savvy parents, and he presented in early infancy with recurrent drop attacks. So he would suddenly become unconscious. He had episodes of distant gaze, unresponsiveness, seizures. He was taken to a pediatrician and they immediately referred him to a neurologist. In fact, he was seen by the 3 leading pediatric neurologists in the city, and they were all perplexed because his seizures just did not come under control. So he was put on 1 and then 2 and then 3, and when the time he presented to our emergency room with worsening attacks, he was already on 4 anticonvulsants. And the family had a huge pile of investigations and treatment history, multiple EEGs, CT scans, MR scans, you name it, they had everything, and they were very conversant with what all had been going on. So I hope this video works. Yeah. So what we found in the emergency room was this is for a 1-year-old child, his heart rate was 60 to 80 beats per minute, very irregular, and his respiratory pattern was very irregular too, with frequent pauses. See here, look at the heart rate ECG trace, and this was the respiratory pattern. So it has a few respiratory efforts, and then it slows down, and then a few more and slows down. So very irregular with frequent pauses, right? So you can imagine that we were lucky. We hooked the child onto a monitor. So this was immediately obvious, but unless the child was examined, I'll show you in the next slide. So the blood pressure was stable and his extremities warm. And this is, yeah. Have a look at his breathing. Can you make out how irregular it is? So this requires a lot of attention and concentration on the pattern of breathing, and most busy pediatricians and doctors are not bothered to spend time just observing a breathing pattern. They prefer to do blood gases, etc. It was obvious it was the same pattern of breathing was mimicked on the monitor, but even without the monitor, careful examination of the breathing pattern would have picked it up. So this child is unable to fix or follow, had recurrent brief episodes of gaze deviation, and the large pile of investigations over the last 12 months had one important omission. What do you think that omission was? One important investigation that was missing. Can anyone tell me? Is anybody listening? Okay, so what was missing was a 12-lead ECG, right? So this child actually has Stokes-Adams syndrome, which is an arrhythmia-induced syncope, which is a Stokes-Adams syndrome is defined as an abrupt transient loss of consciousness due to sudden pronounced decrease in cardiac output. And this decrease in cardiac output is caused by a change in heart rate or rhythm. So an infant needs a heart rate of 120 to 140 per minute, and this child has much lower heart rates and with periods of pauses. The, during the pause, there's no perfusion to his brain stem, and the entire regulation of the heart rate, breathing, etc., had gone haywire. Right? So this child had an arrhythmia, has Stokes-Adams syndrome, and nobody had done an ECG. So it's an important lesson that if a patient has very difficult to control seizures, in addition to an EEG, an electroencephalogram, the child also needs an ECG or an EKG to detect whether the heart rhythm is normal, right? So Suchitra, you're clear about this? Yes. So a model of the story, remember to ask for an ECG with an EEG in difficult to control seizures. So examine the patient and ask for an ECG as well, right? This was another case scenario of a 10-year-old male previously well school going, woke up with chest and abdominal pain and 2 hours later becomes sleepy and he's unresponsive. Unfortunately, he was taken to a local hospital and found to be in full cardiorespiratory arrest. So he's not breathing and he was resuscitated and referred to our hospital. And when he arrived in the emergency room, he's totally unresponsive, no response to pain, no respiratory efforts. And because he was ventilated, we could get his heart rhythm back, but there was no neurological response, no movements of any of the limbs to stimuli, dolci absent. So the question was, is this child even alive? He was being ventilated with 100% oxygen and we resuscitated his heart rhythm, but he kind of fulfills all criteria for brain death. So is he even alive? Well, he did have some signs of life in the form of fasciculations, and over the next few hours, nothing changed really. His hemodynamics were stable and neurologically he remained totally unresponsive. And the question was, what are the possible causes of a near brainstem death-like state? What do you think? What do you think? Any causes you can think of? So he's totally apneic, unresponsive to pain. His pupils are dilated, no dolci. He's got some fasciculations. And this is a previously well child who went up to sleep and woke up in this condition. What do you think the causes would be? So we generally need to sudden cardiac arrest, okay, but we were wondering what the cause is. So there was no history of drug or toxin ingestion, and sometimes snake bite can cause this kind of situation, but there were no fang marks. His MRI was normal, EEG normal, no occult seizures. So finally, we thought we'll place our bets on a neuroparalysis secondary to snake bite envenomation. And even though normally the teaching is you look for fang marks, and somewhere there will be fang marks and exposed digits. But there were no fang marks, but we empirically gave him anti-snake venom and neostigmine and atropine, which is supposed to be good for neuroparalysis. And there was this report that sometimes crate bites. There was a large series from Sri Lanka where they reported that very often the site of bite and fang marks can be indistinct. So there was good evidence to proceed with empiric treatment of with anti-snake venom. So these are the conditions that can mimic a brain death. So you're right, it looks like a sudden cardiac arrest, but we need to know the cause of the arrest, and we need to find out if any one of them were potentially reversible with therapy. That's our job on hand. Because supporting a child's cardiorespiratory system is fine, but if we can reverse the whole situation, that will be much, much better and highly desirable. So these are the conditions that can mimic brainstem death. So fulminant Guillain-Barré. So this is from the Western Hemisphere, and snake bite comes right to the bottom, and a lot of poisonings, etc., come higher up. But in our situation, we thought we could try with anti-snake venom because it's eminently treatable and more common in South India. I don't know how the situation is in the north. So with anti-snake venom, this child who was apparently in full cardiac arrest walked home 1 week later completely well. So it was a good empiric therapy. And the other in case he hadn't improved, the other options would have been to treat as a fulminant GBS, because a lot of autonomic dysfunction can behave with severe bradycardia and loss of respiratory control, right? So can we move on to the next case? Okay. Right. Right. So this was so in ICU is not always like this with very dramatic, interesting cases. They can be quite boring cases, and once in a way we get these very extremely challenging situations. And this case number 3 was such as also very interesting. Came to us about 3 years ago, and the whole diagnosis seemed to be changing every few hours for the first couple of days. So this boy already had a congenital hydrocephalus for which a VP shunt had been placed in infancy, and in the past he's had episodes of shunt dysfunction for which manifested as irritability and headache. So this time as well, when he had the initial 2-week history of altered behavior, upper limb weakness, abdominal pain, the first possibility that was entertained was a shunt infection or a block, which caused worsening of the hydrocephalus and some altered behavior. However, the CT scan and the shunt tap seemed completely stable, completely normal. The ventricular size was normal, the CSF was normal. So he was, because he had altered behavior, he was commenced on antipsychotic therapy with amitriptyline in the referring hospital. And but he didn't improve at all. So he arrived sometime late evening to our hospital for worsening neurological situation. And in addition, suddenly he had an acute onset loss of vision. He was unable to stand. So things were progressing very rapidly. And a shunt was normal, so nobody knew what was going on. And at the hospital late evening, he was febrile. His airway and breathing were okay. He was tachycardic. This is a 10-year-old child with cold extremities and feeble pulses. Even his central pulses were feeble, and his blood pressure is just not recordable with an NIBP. He's poorly responsive to pain. So in the presence of fever, tachycardia, poor pulses, and a non-recordable blood pressure, what is the first thing that we would think of, Suchitra? What do you think you would think of? A child has high-grade fever, and he's tachycardic. He's cold and clammy with poor pulses. His BP is not recordable. What would you think of? Very good. So septic shock is what is important to think of, and because of that, he was commenced on antibiotics and rapid fluid resuscitation, and we thought perhaps he had a CNS focus or any other occult focus, but because he was so decompensated cardiovascularly, he was started on empiric treatment with fluids and antibiotics. So he got fluids, and then because he didn't improve and still unresponsive, he was intubated and ventilated. And when pulses are still hard to feel, the next step to titrate inotropes is to put in an intra-arterial line, because sometimes the non-invasive blood pressure may be very unreliable when the pulses are hard to feel. So the registrar from the emergency room called up the PICU and said something very strange is going on. There's something very strange. I don't know what it is, but this child is not behaving like a straightforward septic shock. So please come and take him to the ICU immediately. So 2 hours later, he from emergency room to ICU, he reached at 10 p.m. and he remained cold, tachycardic, pulseless. All the blood work sent. And he had invasive arterial and central line monitoring. And to our surprise, that initial invasive arterial blood pressure recording was really, really high, 220 on 150 for a 10-year-old child. So now the diagnosis has changed. Number 3, in the space of 3 hours, he's got 3 diagnoses. Hypertensive encephalopathy for evaluation. So we thought he had sudden onset hypertension and therefore encephalopathy, and that. Why do you think his pulses were so hard to feel? So the excess. He was now commenced on labetalol infusion and all antihypertensive therapy, and mental status improved marginally. And he's noted to have quadriparesis and loss of vision. So this was his arterial blood pressure. This is a few days later. He's been changed from a endotracheal tube to a tracheostomy. So look at his blood pressure. He's on 2 antihypertensives, and blood pressure is still very high. Sometimes when there's intense high blood pressure, all the arterioles, the blood vessels constrict, and that's what maintains the high blood pressure. Okay, so to summarize, this 11-year-old male with a VP shunt has a 2-week history of fever, vomiting, abdominal pain. His brain imaging and shunt tap is normal, no hydrocephalus, good shunt function. He's been treated with tricyclic antidepressants and currently has asymmetric weakness of all 4 limbs with tachycardia, high blood pressure, and loss of vision. So again, in this patient, we thought possibly he's got an acute onset Guillain-Barré syndrome with autonomic dysfunction. But it wasn't a very satisfactory diagnosis, and we were still wondering what else could be happening. So you can see here he's had 4 diagnoses, but there was one. I mean, what do you think was actually going on with this patient? It was a very rare condition, and the clue was some discoloration of the urine. So we sent a porphyria workup, and the result was positive, and this was a final diagnosis. And when we looked at the literature, everybody commented that the diagnosis and treatment of this disorder presents very formidable challenges because they mimic so many other common conditions. So the altered mental status and headache was thought to be due to shunt disorder. The difficulty walking and the weakness was thought to be Guillain-Barré. The high blood pressure and poor pulses we thought was septic shock. So the abdominal pain, finally, when you look at it, the whole thing fit in with acute porphyria, and this is first described by Sigmund Freud and Hippocrates many years ago. So imagine cases were sent to Freud because they were thought to be psychiatric conditions, and even this particular patient was treated with amitriptyline initially. So overview of the porphyria is basically inborn errors of heme biosynthesis and can cause life-threatening neurovisceral symptoms and mimic many medical, surgical, and psychiatric conditions. So there's an intense sympathomimetic storm. So just imagine he's got loads and loads of high levels of adrenaline and noradrenaline circulating, which cause so much of tachycardia and systemic hypertension. And in addition, there's an autonomic peripheral motor neuropathy that causes symmetrical weakness. The weakness presents proximally rather than distally, and can usually accompanied by abdominal pain. So this is a rare disorder, but we need to know that therapy is available, but we need prompt diagnosis and treatment. And too often, porphyria is considered only after expensive, time-consuming and unproductive searches for other causes. So if the patient has extremely high blood pressure, abnormal neurological situation, and abdominal pain, this constellation should prompt the diagnosis of porphyria, and it's fairly straightforward to diagnose because you can quite easily detect the increased porphobilinogen in the urine. It's a rapid and simple test and is a key to establish and or exclude other diagnoses. If you want to find out the exact mutation, we can do DNA studies to identify and confirm the diagnosis. So the first thing we need to do in the ICU is remove porphyrogenic factors. So drugs, there's a whole list of drugs that we need to have available, including antipsychotic drugs like amitriptyline, which he initially received and worsened the porphyric state. Starvation can worsen the situation, and as also alcohol, which may be a situation in older adolescents and adults. For mild, starvation and low glucose can precipitate attacks, and for mild situations, IV glucose alone is very appropriate. That means they present with just abdominal pain alone and no paresis or hyponatremia. We can use beta blockers which reverse that intense catecholamine storm and monitor for weakness, hypoventilation, etc. Hyponatremia is usually a common occurrence. We need to give adequate pain relief. So always check the drugs, which drugs can worsen the porphyric state, and if available, intravenous heme, which the family has some contacts in UK, and we were able to import intravenous heme. So it's very hard to get, but it can dramatically reverse the situation. So this is the treatment who is of choice. So in mild conditions, you can give IV glucose alone, but any situation where they are very symptomatic, we need to give IV in hemin, which decreases the overproduction of ALA and porphobilinogen. So this child remained, so the cause of blindness was, what do you think the cause of blindness was? Blindness is not usually described in porphyria. The cause of blindness was just effect of the intense hypertension. So it was a hypertensive emergency, which can cause more of neurological manifestations, eye manifestations, including blindness. It can cause myocardial failure and acute renal failure. So he did not have, surprisingly, his heart function remained stable, his renal function remained stable, but he was left with blindness. You can see him here that he was able to bear weight a little bit, and gradually his muscle weakness improved. But even though, I mean, we took about 48 hours to reach a diagnosis, but sometimes it can take many weeks for a precise diagnosis to be made, because people just don't think of it since it's so rare and it mimics so many other common conditions. So this was a very good learning experience for our entire team. So the final case, the fourth and final case is a short case which may be familiar to you guys. This was, okay, I'm sorry, the first slide is missing here in this case. This was a 2-month-old infant who was referred as a refractory pneumonia and some hypoxemia. So the child had respiratory distress, saturations of 85% in room air, features of compensated shock, and a liver that was 3 centimeters below the costal margin. Initially thought to have a pneumonia, but what are the other possibilities? What do you think? A child with 2-month-old with respiratory distress, desaturation, compensated shock, and this was the X-ray. Any thoughts on the underlying diagnosis? Okay, congestive cardiac failure. What do you think the cause might be in a 2-month-old? You're telling me the end result, but I need to know what any possibilities about the cause of failure. So you can see there the heart is small, right? The heart is small, but the lungs are congested. So what do you think might be happening? Usually in congestive heart failure, the heart is large and the lungs are wet. So this patient was given fluids, antibiotics, but he had worsening distress, had persistent hypoxemia and metabolic acidosis, which just did not improve despite 100% oxygen and PEEP. So this baby, on echo, he was found to have an obstructed intracardiac TAPVC. And this is an important thing, as you cardiologists might know, that many of them can present with respiratory distress, bilateral infiltrates and chest X-ray, severe hypoxemia that is refractory to oxygen, small or normal heart size. And unless you think about it and do a call for an echo, we might never know. So always rule out congestive. I mean, even when you think about congestive heart failure, we need to think about quite a few children have been referred as refractory pneumonias, and even our ICU fellows have done a screening echo and picked up abnormal right-sided dilatation and called for definitive echoes. So that is our fourth case, and that's the end of my session. Thank you very much. I hope you learned something useful from this.